This is not a mandatory lecture, it's just, but it's not a lecture in truth. Good, yeah, okay, good. So, yeah, everybody should end up with a copy, your own copy, mark it up to whatever you want with it, okay? This is a very brief presentation on, that really just sets up the discussion of this protocol, okay? So that's what I really want to do, is just discuss the protocol. So, up until March 30th of 2015, this was an unbelievable mess. Temperature management here was an unbelievable mess. It was 33 degrees. It was done with anything from a cooling blanket to iced saline to the ER had literally an immersion bath. And as soon as they put the patient in the bath, the first thing that they would do is have a bowel movement. And it was filthy, disgusting. I mean, it really was gross. We had zero data. We had no idea what was going on. Everybody was doing anything that they wanted with shivering. The shivering protocol was a disaster. Virtually everyone was overdosed on Demerol, is actually what was the shivering protocol. It was insane. And no one would take responsibility for it. So one day, John Disson and I said to each other, we had a conversation, and we said, should we take this over? With you guys, with the residents. And John thought for a while, and he said, look, the purpose of TTM is to protect the brain. That's ours. Therefore, we should do it. And I said to the ICU committee at the time, fine, we'll do this, and we did it. I've always wanted to do something that I've done several times since, and that is as a project management. The project management style, there's what's called the Toyota Reengineering project. So a Toyota Reengineering project has one rule. From start to finish is 90 days. From the minute you declare go to the minute you stop is 90 days. You can involve as many people as you want. You can redesign a spark plug, or you can create a new car, but you only get 90 days to do it. And you bring in all the people that you need. And if you are not done by the close of business on the 90th day, the project ends anyway. It's not done, and that's the end of it. It's over. So it really has a hard stop. So we did the same thing, and we brought together approximately 30 people. I wanted to do a Toyota Reengineering. I've always wanted to do that, and that's what we did. We did a 90-day project. This was the result, which then got revised. It says March 2nd of 2018, and actually it was March of 2017, and we're still waiting for approval of the revised version. Okay. The reasons for the original revision were here. The asterisk shows that we're still not collecting data. There's no one to collect data. Maria, you have some data. We have some data, but not everyone. We don't know everyone who has TTM. I couldn't even tell you how many there are right now in the hospital. And these were the things that were going on. No indications. No one knew what they were doing. It was nothing. It was just simply nothing. We did the 90-day reengineering. We had everybody involved that you could imagine at every level, both, so it was both vertical and horizontal. And we made extensive use of the literature. So this is what we did, this process. We divided our task force. It was called a task force rather than a committee because it was self-limited. So everyone who joined, see, that's the thing about the 90-day. You have no commitment beyond 90 days. So people were much more willing to participate, knowing that it wasn't an open-ended affair. Okay. It also makes you speak quickly because you have maybe 4 or 5 one-hour meetings of the group, and that's it in that period. So it really forces efficiency. It was an excellent thing. We did it to reorganize Klein Clinic as well, the 90-day project, and ophthalmology. So we've done 3 of them now. Every one has been tremendously successful. We had these 6 subgroups that the group decided on. We reviewed the literature extensively, and that's why when this protocol is done, it's a protocol. We don't want variation from this protocol. We want you to adhere to the protocol, everybody, okay? Because if you think that you have a better idea, then you need to put the literature in front of us. Everything is literature-based and then vetted with experts from all over the country, okay? So we must have had easily 100 conversations with experts on various topics, okay? Within the committee, when I run a committee or a task force, there are 2 rules that I always put in place. Rule number 1 is there are no votes. It's like a Quaker meeting. You discuss until you reach a sense of the meeting. There are no votes. We did this whole thing without a single vote. And the other thing is that the most important voice at the table is the dissenter, another Quaker principle, okay? And that way, everybody walks away, no one walks away getting everything that they want, but everybody walks away knowing that they were listened to, okay? And in order to choose the Arctic Sun there were 6 different devices that were available. We had a day. We took over BPOD in the ER, and we had all 6 people, all 6 vendors with their machines demonstrating on people. We had a standardized assessment tool. We had every ICU nurse, every ER nurse, every neuroscience nurse, every OR, every PACU nurse came, and on a standardized assessment scale, rated all of the machines. We then took the data and bought the Arctic Sun, which won by a lot. And then the final thing is that the changes that were implemented were 2 weeks away from when we were ending our report. So, 76 days or whatever it is. Nielsen's paper came out, which I'll show you. And because we were originally at 33 degrees. Throughout the entire 76 days, we were planning for a 33 degree. Then the 36 Nielsen's paper came out 2 weeks before we were done. Everybody reviewed the data. We re-met for another and decided 100%. It was absolutely unanimous to switch to 36 degrees based on the paper. We were evidence-based to the core. We read this paper and we were done. So the concept is that you have targeted temperature management. It's really not a matter of hypothermia, which is why you don't leave alone someone who's at 34 degrees. Okay, it is a process of maintaining a controlled targeted temperature and avoiding fever. The idea is to avoid fever and maintain control. And the period of temperature management extends way beyond the cooling. That was what was happening. You had all these people down to 33, then you stop, and they all had fevers. I mean, yeah, they just, it goes through the roof. And there was nobody, and everyone was going, now what do we do? Okay. This is the paper by Nielsen. It was a New England Journal article. And we believe that it was a good paper. There are many criticisms of this paper. There's a lot of people who say, I'm not sure it applies, I'm not sure it's our group. We thought it matched our group very well. So we didn't have a problem with it. We thought it was a well-conducted trial, that it met, absolutely first class. You have that star rating system that we talk about in EBM. You go down the star rating system. This is a first class paper. And the authors of the original paper who wrote the 33-degree paper wrote an editorial with it. And they said, look, all we did was leave uncontrolled versus 33 degree. We didn't look at any other temperature, okay? This is a wonderful paper. This is an advance to the next level of evidence over what we did. We love this paper, okay? Those were the people who had published the original study. And there was no difference in outcome between 36 and 33 degrees. And when we looked at it, given that there was no difference, okay, then we looked at, this is a list of the advantages of not being at 33 degrees. It takes up a whole slide in small print, okay? And just look at them. This is, you don't have ventilator humidification, pH correction. You have less hypokalemia, less insulin resistance, fewer electrolyte, less shivering, less coagulopathy, and you didn't have to exclude people who were coagulopathic, okay? It was much easier to do. When the nurses first started doing 36 and the Arctic Sun, I remember a CCU nurse coming out and saying, I put the pads on and pushed the switch. Is that it? And we said, yeah, that's it. And she's going, blood work? I said, no, and she just went, this is ridiculous, and less risk of cardiac arrhythmias. Okay, there is a power plan. This will eventually be a modified power plan. I'm still the one responsible for all this, and we're still waiting for the revision. Okay, and that's it. So basically, we can go through this if you want. I definitely want to go through the shivering protocol with you. But other than that, it's a Q&A. And we can start with the question that I think someone raised, or Stephen raised, and that is, what if the patient comes in at 34? The large majority, 60-something% of the people who come in after cardiac arrest are below 36 degrees. Okay? So this is a large, this is the usual, and the answer is put them on the Arctic sun, and the Arctic sun will warm them to 36. It has a programmed approach to it. If they are below 33, it warms them at 1 degree an hour until it brings them to 33, and then it raises them at 0.3 degrees an hour until they hit 36. So everything is evidence-based, everything is protocolized, everything is controlled. This is, we spent untold thousands of hours, given the 30 of us and the work that we did in that 90 days, there were thousands of hours went into this protocol.
Dr. Newman, that point, if you could put it in an email for the other attending, because now ICU consults are done with all the attendings, and they all have differences on that aspect.
So they should read the protocol. I mean, they should read the protocol. I'll get it to the
At least 3 times
faculty.
in the last week, I've been told, don't put them on the Arctic sun. They're already at 34, leave them alone.
That is simply not correct.
Yeah, and I always fight to stop on that.
I don't fight back because I don't want to get in trouble with any attending.
Well, all you have to do is refer to the protocol.
Okay.
It's a protocol. It's meant to be followed. It's a power plan. It should be swallowed whole. Okay. But I will send an email and try to get it in here. What else? You understand that you do not have to call the 2 cats attending. If you and the treating team agree that this is either yes or no, whichever way you agree, you're done. Okay, you don't need to clear it. You only call the 2 cats attending if you and the treating team are not confident one or the other is correct. Any disagreement or non-disagreement, but you're not sure, call the 2 cats attending. The reason that you were involved, so why neurology residents? There were 2 things that we needed. We needed a pre-morbid Rankin, okay, and you are the ones who know how to do that. The other thing is that what we needed was a corporate memory. So the idea, do you know what I mean if I say a corporate memory? So there is no way, let me tell you something, there's no way to write a protocol or guidelines or anything else that answers everybody's question. It would be so long, no one would ever read it. So what you develop in any system, this is whether it's a business or whether it's the medical center or whatever it is, you develop a case-based history, okay? So we discussed this, right? You all see the patients, okay? There was only 9 of you. So there's only 9 people that A, have to be trained in it, B, that are going to come in contact with this question, okay? And we sit as a group, as we're doing right this minute, and discuss it. So not only do you get your own cases, right, but Stephen comes in and says, I don't know why, or someone comes in and says, I got a question about 34. And now you know. So you are the corporate memory. You are the experience of the medical center. Every patient since April 1st of 2015, every TTM patient has been seen by a neurology resident. That's an amazing statement. I mean, that's a uniformity, and has been treated with the Arctic sun, and has been treated at 36 degrees. There's a uniformity that was lacking before. Okay, so you are that's we debated lots of other, whether it should be the RRT nurses or we and this was like I said, this was the task force ended up choosing neurology residents. Okay.
So, excuse me,
So overnight, we do not have to call the attending unless.
Only if there's a disagreement. You don't need to call the attending at all. I mean, you really don't. If you and the treating team agree, that's the end of it. You're done. You don't need to tell me or anybody else. I mean, it's. I'll say again, if you disagree, or you don't disagree but you're both not sure, call. That's fine.
And to give them some more sleep, because I feel guilty waking them up for this.
And you don't need to just say, we're putting the patient on TTM. It's like, okay, you know, okay, fine. You know, it's like, what do you want me to do? It's like
And there is no point in doing TTM after 12 hours of the ROS?
we believe that, I think that's what it says, is 12. It's somewhere around 12, right?
So some of there's no need to start.
Yeah, I mean, that's less of a hard and fast rule, but isn't that worded to say after 12 hours, you're sort of wasting your time? And that was meant, when we want it hard, we make it hard. When we want it soft, we make it soft. So what is it? Patients not started on TPM within 12 hours should be considered beyond the therapeutic window. It's not saying don't do it, it's just saying, ugh. And I probably wouldn't, if you don't want to do it, here's a good excuse, okay? But if we said, it does not say, do not start beyond 12 hours. If we meant that, if we wanted it to say, do not start beyond 12 hours, we would have written that. Every word has been vetted by over 30 people, every single word. This is a very careful protocol. Notice the resuscitation status, for instance. I can't tell you. I mean, there's a whole committee dealing with, you know, a sub-task force dealing with the question of DNR. Okay, so if they have an active pulse prohibiting resuscitation, or a surrogate decision maker rejects the essential components of resuscitation, then all efforts. And that was one of the things that Penn was very helpful with. They said, what if you resuscitate the patient? So the patients resuscitate, right? 911 gets called. The patient is at a community center, and they start resuscitation. They conduct the resuscitation. They continue, they bring them in, they continue the resuscitation in the emergency room. And then a family member walks in and says, are you crazy? He's demented to the point that he hasn't known anyone in 5 years. He has DNR orders all over the place. I don't know why they didn't give them to you. Okay, but we didn't want him resuscitated. Here's his, you know, pulse. So then the question is, what should you do with the TTM? And Penn's answer was, it's not the TTM. You should stop the resuscitation. TTM is part of resuscitation, period. Okay? If you don't want to use TTM and they were eligible, then you shouldn't have been resuscitating the patient. What are you doing? Why are you resuscitating the patient if you don't want to protect their brain from injury? You know? So if you feel like TTM is not right for this patient, it's like, what are you doing? But there are specific criteria that you participate with, which are considered relative contraindications.
So if the patient is already resuscitated, that's usually the question they ask us.
They're often still resuscitating, and they have another one, and you know, and they go back into cardiac arrest.
Yeah.
But let's say they're done. So all right, so they now have ROSC, right?
Tell us, like,
And this guy is intubated, of course. He's still paralyzed coming out from or not, it doesn't matter. He's 34 degrees, okay? And a family member walks in and says, that was a mistake, okay? What would I do? I would say, okay, I'm sorry, we didn't know, okay? ER doesn't ask, okay? They really can't, okay? In comes a patient, you know, it's like, okay, this is what we're doing, okay? Now you've told us that, all right, we're not only are we not going to put them on TTM, we're not going to hydrate them, we're going to make them comfortable, we'll leave them on a ventilator, but that's all. And you know what? Get them upstairs into the MICU, and if you want to extubate them, talk with the team, they can extubate them, and we're done. TTM is part of resuscitation. It's just part of resuscitation. And that's what it says here. Given 36 degrees, it is presumed that most patients who meet the inclusion criteria will be eligible. Right? Reasonable exceptions, so you know that anything that was futile, someone comes in with a platelet count of 2,000 and advanced liver disease, not on the transplant list. This guy is not going to survive. You don't have to put him on TTM if you don't want. Poor baseline status defined by the modified Rankin that you know better. You're the only ones who do know what that means, okay? Comorbid, and the other one is if they're in septic shock on one or more vasopressors.
That
Only
gets
septic shock.
confused. It's septic, not
Septic,
hemodynamic.
Septic, they're, of course they're going to be in
Cardiogenic
cardiac shock.
Yeah.
I mean, that goes without saying, it's septic shock.
I have a question about like initiating TTM in the ED for patients that are like on a catheter, like they might take them to the cath lab.
Sure, I
Do you
think
do
that's a great
before?
question.
Do you do after?
So the Arctic Sun pads were designed with the cath in mind. They don't touch the groin. So what you do, this is what you should do,
Mhm.
okay? And this doesn't happen often because the catheter can move very quickly.
Right.
But if you're waiting, so what you should do is put the pads on, cool them, okay? Get it going, okay? Then when they call, just disconnect the patient, just drain the water, disconnect the patient. The pads will stay cool for an hour, okay? They're here, they're not in the way. Don't bother rolling the machine in, just let them go with the pads on, okay?
Okay.
And let them do the procedure. The pads are nowhere near the groin,
Mhm.
okay? And then bring them back and hook them back up again and start it over
They were
again.
made for it. Like they were made when they were designed as
Yeah, yeah.
a device. They were made with cardiologists.
Okay.
meaning
And,
they-
and that was one of the selection criteria. Remember I told you that we had 6
Yeah.
vendors in, and everybody looked and said, wow, this is great. See, you want to send them to MRI, do the same thing.
Mhm.
They're in the MICU, just disconnect the machine, seal it, okay, and send them on. Okay, that's the idea. You can send them wherever you want, including to the OR for a quick procedure, central line, whatever you want, IR for a PIC. I mean, just don't leave the pads on.
Okay.
They're not in the way of anything. Okay? There is a large pad for people who have a very large girth. There's an extender that you can use, we have. And the Arctic Suns were expensive. They were $50,000 each. We have 5 of them. A set of pads is a little over $1,000. So the network made a commitment to do this right. You know, we walked out when we had all the scores, and the Arctic Sun won hands down from the nurses. You know, the network shelled out $250,000 to make this happen.
And the pads, they're not reusable?
Pads are not reusable and have to be changed every 3 days. And you have to check for skin breakdown. They do, some people have problems with skin breakdown, but the nurses know that.
Yeah, they-
Could we clarify the time, sorry? Active cooling or maintaining a 36 for 24 hours?
Maintaining a 36 for 34 hours. So all the times are defined precisely. That was another thing that was not done anywhere. This is the only protocol in the United States that defined times. Every other protocol was deficient in that. We looked at 50 protocols easily, and no single one of them defined the start time the way we did. So the start time is defined as reaching 36 degrees and continues for exactly 24 hours. And then there is a period of transition that's about 3 hours, because you're going at 0.3 degrees an hour. So you'll hit your target, assuming your target temperature is 37. We left some flexibility in target temperature. I like 36.8 personally, but I don't care. When you reach your target temperature, that's when the 72 hours starts. Okay.
So it's 36 for 24 hours, and then we want to 37. And at that point, it's 48 hours, right? At
36 or 48 or should be.
Whatever it says.
That's what I'm trying to find out. I just wanted
I've
to.
always
it'll
done
say.
36
Yeah.
for 24 hours, and then rewarm for 48 hours.
Yeah,
So
that's
72
what I
hour
thought.
total.
Yeah.
Okay.
Warm it takes
Right.
time.
I just want to mention one thing. There's been a recent spate of case reports that just came out of people who quote unquote awoke from brain death. And in all those cases, it was because people prognosticated inside of that window. Meaning
Right.
they weren't done rewarming and they
Right.
prognosticated, they said they're brain dead and they can't. So you guys need to know that because you're
Bad
gonna have
idea.
teams who want to get you to prognosticate and you can't say anything at all. They could be
Yeah.
meet brain death criteria in that first 72 hours and it's meaningless.
So, I think that's a very important point, and we make that, that is explicitly in here, that you should not offer prognostication before 72 hours. I will say this, however, that when you, here's what I do with a family. So if, let's say that they've been warmed for 24 hours and they have no reflexes. So what I let the family know that tomorrow, so we know that we should not offer a prognosis to you, and I'm not gonna do it. But I gotta tell, and we will tomorrow, so let's set up a family meeting. However, I just need to tell you that I'm concerned about what I'm seeing right now. It's a little bit hard to be optimistic, but we'll see, it can happen. But I want you to know, I'm concerned. I like the word concerned. I'm concerned because you don't want to just drop, hi, we're going to go and do a brain death exam later. I don't like to do that. I like to let the family know that bad news might be coming. You're not giving them the bad news. You're letting them, and you're leaving it in an uncertain. You say, we'll see, because things could turn around real quick in the next 24 hours. Okay, think about it. Get comfortable with it in your head. But I'm concerned. Okay, there are some things I don't like. I may even go over with them. I don't see any reflexes right now. It's like, he's not breathing, he's warm, and, these seizures, I can't get them under control. It's like, but we'll see. Maybe we're doing everything we can, and we'll see over the next 24 hours. That's how I talk to them.
I call it managing expectations.
Yeah.
Make sure that they know things could go bad, but that we can't give them a definitive answer. But my bigger concern is with the teams, because the experience that I've had here and elsewhere is that they want to push you to sort of say, oh, but look, everything's awful, it's terrible. And you have to really, really tell them, you can't say, don't tell the family. You can be, like he said, maybe things aren't so good, but make sure that they're not telling them, oh, this is it. There's no point. Because then it sets up a situation where you're going to have drama. You're going to be like, well, Neuro said this, and they said this, and then suddenly the family is focusing on whoever said the best thing,
There is a comment in here that talks about absence of brainstem reflexes, which are not, you come in. So here's a question that I get from you guys. If I do get a call at night, it's often something like, okay, the patient, and he has no brainstem reflexes. Therefore, should we put him on TTM? And my answer is that presence or absence of brainstem reflexes is irrelevant to this decision. I'd like you to know, I want you to know it. That is, I want you to note in your note that there are no brainstem reflexes. It does help me with prognosis, some, although I'm not going to share that with the family, but it's good for me to know that this happened, because when I see him as a consult tomorrow in the ICU, I want to know what your exam was. But it doesn't play any role in whether they go on TTM or not. Also, there is unless you have suspicion for an intracranial hemorrhage or some other disaster on your own clinical grounds, okay, you do not need a CT scan. They don't need a CT scan to start TTM. If they want to go get a CT scan, anytime they want. They can disconnect the machine, send them down for CT, get their CT, bring them back up. Get the TTM started, don't worry about CT. Now, if the story was that he fell over with a hemiplegia and then had a shortness of breath and then had a cardiac arrest, probably it'd be a good idea to get a CT scan, right? But that's what you should be hearing before you recommend a CT scan. You have no reason for it. At the time of, common things, at the time of prognosis in that last 24-hour period, usually if the patient, in fact, I believe that it says it here, there should be a section on prognostication. And I want to get to the shivering protocol. And post-rewarming, here. So on page 9, Roman number 12F. Although prognosis should be reserved for until 72 hours after achieving the rewarming temperature. See, that's what I believe. That's what it's.
What are you looking at?
It's 72 after achieving rewarming.
Oh, really? I thought it was
96 hours.
Yeah.
96. It's 72 after rewarming.
some places do that and some places don't, that full 3 days. We didn't have it set in a protocol at either MGH or Columbia, but that's basically what we did. You know what I mean? Like we
Right.
functionally
3 days
did
of
that.
rewarming.
After, yeah, we functionally did that, meaning we gave them like, let's give them 3 days, full court press, see what happens.
But here it is part of the
But he
protocol.
put it in the protocol. The only other thing I wanted to ask, because I saw this, because I don't necessarily always do this, but if you want to protocolize it, it's fine. If they're hypothermic after ROSC, I don't always set up the.
So we do,
thing.
we
That's fine.
we want them
Okay.
warm to 36.
I can do that. I
Yep.
wasn't doing it before.
Yeah.
But I'm happy to do it.
Okay.
It's just, we didn't do it in any of my training. We would just leave them and let them rewarm themselves. But that's fine. It's an easy change.
Right, and it says, if you go get to 12A, post-hypothermia,
Mhm.
continue full temperature management for up to 72 hours. And we'll come to, and then also notice, and this is another common question, is what if the patient appears dead? Okay, so first of all, if they appear dead during cooling, I don't want to know about it. I don't care, okay? If they have been rewarmed if they've been rewarmed and they would otherwise meet brain death criteria, and I mean full brain death criteria, then you can declare brain death by us. Now, you're, Nanda, saying that there have been some exceptions to this?
A number actually have been coming out. It's really interesting. They're just coming out now. I've seen already
I mean, if we
reports of
see,
3 or 4 cases where people were declared, and it was just because they declared them inside of these windows, and then they got better.
so, we'll,
On the organ transplant.
Yeah, the
I
kid
read
was
that
on
when the
organ,
kid,
he's about to
he
go to
was,
the
he's
OR
on
to be
the
harvested,
BBC and everything.
and they started
He was
warming.
brain dead, they were harvesting, they were going to cut
Yeah,
him.
they were cutting him.
He woke up.
Yep.
It's
So,
crazy.
You know,
He's home now.
it's not crazy, it's just people not knowing.
Yeah.
One, they may have done the brain death protocol incorrectly, so that could be part of it,
Yeah,
and the other
I
thing is
don't-
outside of the protocol.
yes.
I did want to talk about, because maybe you and I can talk about this separately too, is the shivering.
No, actually, it's good to have a
Okay.
conversation. openly.
Because I'm trying to look at what you do for shivering, because there's 2 things
Okay, so
actually
let's go to the shivering
actually,
protocol.
before you do shivering,
Okay,
before shivering, I want to talk about EEG. So
Yeah, I'll
my
say.
protocol at both places and in my practice, like in training and in practice, was we hooked up EEG right away.
and
We
there-
didn't wait.
well, so, and I have to talk to
And
some
there's-
of you over this weekend. We don't have that kind of EEG coverage.
Right, we don't have the ability.
So we put the EEG
After
on
week
here.
1, right?
There are requirements,
It says here, yeah.
so.
Well, I have 2 reasons, let me tell you my 2 reasons for doing it. One is obviously for seizures, but that makes sense in terms of you waiting for seizures. But 2, it's for micro shivering, because I think that in these, what we saw, what we observed, and and this was in cooling, okay, so it wasn't TTM, it was cooling. We saw way more shivering at the transition points, and it was micro shivering, and that was fighting the fever.
So what I would
So-
say is.
And I want to treat micro shivering.
Yeah, so what I would say is, number one, that you need to learn to look at the Arctic sun, because there are 2 useful numbers to the Arctic sun, and you can graph them. I always recommend graphing them. And that is patient temperature and bath temperature. And you can have a very stable patient temperature, and the bath is down to 8 degrees, okay? That means it's working its ass off. And not only that, you increase the likelihood. It's not a good idea to leave them at 8 degrees on that water, because if you do that for over 8 hours, I think, you start to injure the skin.
Right.
So you don't want sustained low temperatures with the machine. You'd be better off easing the temperature up a bit like you would in the shivering protocol, which we will come to. The other thing is, so then you can see micro shivering, because the machine is working hard, and the people who are not shivering or micro shivering, the bath temperature is going to be 32, 33 degrees, okay, most of the time.
But I think the trouble is happening because, so you
So-
can sometimes see micro shivering on
But we
the
don't
KG.
have EEG
Right, we don't have the
coverage, like, we
capability,
don't have it.
which is fine. I mean, that's a different sort of consideration, but the issue that we're having is, the nurses aren't believing the micro shivering. Like, so I've had that discussion with them about the bath temperatures on my own when I've seen patients. And they're just like, nope, they're not, they're not treating because they don't believe it. And so it's, resource management aside, we have to find a way to sort of convince the nurses that we need to be doing, well, because they're never doing counter rewarming. Like, they don't do bear huggers or anything like that. So this is why I was gonna say we could
Right,
talk
well,
about
let's look at the
separately.
shivering protocol, which we want to use, and if you think that they're micro shivering, I would speak with the attending and get the attending to
They
tell
don't
the
believe
nurse.
it either.
Well,
It depends on where they are.
and that's the problem.
Yeah, that's what I'm saying. I'm saying it's not just the nurses don't believe it, but then they're like, no, screw neuro.
You can
And
lead
it
a horse to
doesn't
water,
either.
but a pencil has to be led.
Right,
okay?
right.
It's like-
But with the shivering protocol, I feel like we have a difference of opinion.
The EEG is supposed to go on within 16 hours of initiation.
So
I
that
can't.
is
They should have
always
cooling
a
or
problem,
warming?
because if
Well, it
someone
shouldn't be.
calls on a
16
Friday,
hours.
then they have to come in over the weekend.
Yeah,
And that
they
is
do.
what happened this weekend, and
Well, they
Jessica
have to
wasn't
come in.
happy.
No, they have to, it's
She
part of the
was-
protocol, they
She
have
was
to come
very
in.
unhappy about it.
I'm sorry,
And, yeah, so
protocol.
that's what I don't know what to do about that. And then they complain that I called them in.
I will
Yeah.
speak with them, it's part of the protocol, and 16 hours was a gift, okay? Instead of coming in at 2 in the morning, you're coming in on the next business day, I mean, give me a break.
So
That's-
there's two places where I think we're gonna disagree on shivering and sort of, and we can talk about it, is number 10, which is the meperidine.
Right, so
I
we
know
don't
you don't
want the
like it.
Paragon
You
used,
don't
no,
like
we
it.
don't want it used. The reason, Amanda, isn't that it doesn't work, it's that when we took this over, you missed the intro, everybody was overdosed on the Paragon. Because
That's
it
'cause they're
doesn't
not
work very
treating it very
well, and they just massively load them with the Paragon.
What about
So we-
Buspar?
No, that had several dangers associated with it. It wasn't very good, and it had several,
But that sounds like it's
complications.
nursing related, it's related to
no,
how
well,
they're using
everything, this came out of the literature, we reviewed every article written on shivering to create this protocol. Pharmacy, ICU, ER,
Right,
there
far
were,
be it from me to get into, I wasn't there for
Um,
those, I wish I could have been part of
any
those
part of
discussions.
this protocol can be amended,
We can,
but
but
you're
that's why I'm
gonna
saying
have
we
to
can,
produce
I
better
hear you,
literature
I
than
hear
we
you.
have. That's
And
what
I'm not
saying.
gonna mess
Yep,
with
yep.
that. That's why I was saying we could talk other.
Bring the literature.
I'm okay, yes, well, yeah, as you know, we have, some
It
people
has to
have
be
different.
studies, I don't wanna see an
People
expert
have
opinion.
different, of course, people have differences of opinion on their interpretations of studies, as you well know.
We can have those discussions, I'm happy to
Anyway,
do that.
but I'm gonna follow the protocol,
Okay,
guys.
thank you.
Yes.
I
I'm just telling you, I
appreciate
may have, I want
No.
you guys to know this, we have healthy debate,
And-
that doesn't mean protocols are important,
And
they're
I'm
very
absolutely
important.
open to amend the protocol,
No, I
I mean it,
But
okay?
I'm here to tell you guys that protocols are extremely important, once they're made, you can make amendments, but before, you shouldn't make amendments on the fly, right? So if you
Right.
hear me on the phone, and I say, give this or do that, and you're like, oh, Dr. Fine, it's not in the protocol, I'll be like, okay, that's fine, let's look at the protocol, make sure we're right, because I may be doing stuff for my own practice, but you should be checking me, does that make sense? Because especially since I'm coming here, learning the protocols here, so just always, me and other attendants, so
Yeah.
anyone who's saying something that's off protocol, be like, are we doing this off of protocol on purpose? Like, what's your reasoning for it? And you don't feel bad about questioning attendance, okay? Because it could be force of
Or
habit, it
making
could
it,
be,
or bringing an article in the next
Right.
day and say, look, last week,
yeah.
look, and we
I
can
won't be
amend.
offended, like, I'm not offended if you guys say,
You know
oh,
what?
Dr. Fine, it's not on the protocol, I'll be like, well, I don't wanna do it because of X, Y, Z, and that's I'm gonna put it in the note, I'm going off protocol for whatever, and then Dr. Newman can be like, we're off protocol, and the wrong answer, blah, 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 right?
Let's start on the bottom of page 13, I want you just to look at the BSATs, the bedside shivering assessment scale. It's incredibly simple. 0 to 3, okay, there are some guidelines as to what it is. The guidelines are usually very muddy, but the nurses will just assign a number, okay? So, all right, so this is your BSATs, okay, so let's go over.
Should we put this one in red?
Say again?
Should we put this one in red cup? The bedside shivering assessment?
Yeah,
I think it's
absolutely,
simply
we
a good
can.
idea.
Yeah, this
Wait,
was new,
You have
this was,
P-Star, you have P-Star.
so, yeah, but look where it is.
Is it more? I know, but still, it's on it. But wait.
So
what-
let's go through the protocol.
Okay,
Let's just go through the
Because
protocol.
I'm upset that there's
So-
no bear hugger on here.
There is.
No, there is.
Oh,
That's
there
it.
is,
That's
okay,
number
all
2.
right, I'm not offended. All
It's
right,
very,
take it back,
go through
take
the
it back.
protocol. So if a patient on the TPM protocol begins to shiver, evaluate it with a BSAS. If the BSAS is greater than 1,
Not equal.
not equal to 1,
Yeah.
greater than, I'll say again, every single punctuation mark in this protocol has been reviewed several times, okay? And I mean
So
that.
you have excluded micro shivering with that, right? With the B-Sat
Exactly.
degree.
That's correct.
That's
correct.
my issue.
So
That-
is that what the ICU is following?
That's
the
why they're
protocol?
doing this, right. So that's an issue.
Follow the protocol. If we want to review the
do.
literature, then we review the
Okay.
literature. That's fine.
No, I'm not gonna do it now, I gotta move.
Until the BSAS of 0 to 1 is achieved. And so number 1, okay? ensure adequate sedation, usually with propofol and fentanyl, and it goes further and says that if the patient is on midazolam, consider changing to propofol. It's not a requirement, but consider changing unless contraindicated, because propofol is better than midazolam for preventing shivering. Okay? So there. Number one, that's with the patient on propofol and fentanyl, or midaz and fentanyl, and I like fentanyl, I really do. Ensure that the magnesium is over 2.
This is important too because the nurses fight this one. They don't understand, the nurses and the teams don't understand that we're doing it not for cardioprotection, we're not repleting them, right? We're not repleting the magnesium, we're shooting for a target.
So the problem is they haven't seen this protocol because it's been sitting in the nursing office for 1.5 years.
Yeah.
Okay? I recommend, honestly, that you take a photo of this on your phone and keep it with you.
Are we the first people seeing this protocol? Like,
You are-
among the clinical staff?
Yes, other than
Okay.
nursing administration, you're the first people
Right.
to see this protocol. This is a vast improvement over the last shivering protocol.
Very high.
So bring the magnesium greater than 2. If the BSAS remains over 1, 30 minutes after sedation is optimized and the magnesium is greater than 2, then, right, that's how this protocol is written, step by step by step. Add a bear hugger for surface rewarming to a maximum temperature of up to 43 degrees. If the BSAS remains over 1, 30 minutes after surface rewarming is optimized, then increase the Arctic sun temperature by 0.3 degrees every 30 minutes to a maximum of 37.2. If they remain the BSAS greater than 1, 30 minutes after that, increase the propofol infusion rate toward the maximum. 30 minutes later, add Tylenol. Okay, right? Maximum doses of 8. Very standard stuff. If greater than 30 minutes, it's still BSAS is greater than 1. Raise the serum magnesium up to 4 milligrams.
So who wants to do a lit search shivering project with me? Look at GC. Oh my God, there's so much interest. Let's all do it. No, we can do it. Let's have a
Can we
shivering
use the
journal
Red
club.
Cup database?
What?
Pardon?
Can we use the Red Cup database?
Yes, absolutely.
Okay. Well, you can start with just having a journal club.
Um,
Go over it that way.
Completely open, but Jen Udall and I did look at,
I
like I
believe
said,
it.
all the literature
I'm
that we
new.
could
I
find.
want to participate.
Good.
I want to participate.
So then, after you have them at the mag of 4, so now you're at number 7, where it gets a little hairy. Number 8 is indented simply because it's done in Word rather than WordPerfect. The next step depends on the blood pressure and will involve either dexmedetomidine or buspirone. And you can read what it is, set according to blood pressure and heart rate. We prefer that you use Precedex, but limits by heart rate and blood pressure. If you can't use the Precedex because of heart rate and blood pressure, use the buspirone, although note that you should not use it in people with a creatinine clearance less than 30.
Are you suggesting switching to Precedex or
No, adding.
Okay, that's what that just wasn't clear to me.
So we do have people on both propofol and Precedex. I haven't seen that.
They
I
would like to
haven't
do
seen
it.
anybody get to 4.
Get there,
Okay.
yeah, get there.
All right, so the one that almost always works, the truth is, I haven't had to go beyond 3. And all the time that I've been doing this since 2015, I have not had to go beyond 3. This protocol, beyond 3, is window dressing. Okay, that's what I would say. And then, if after either Precedex or buspirone, they're still shivering, paralyze them, simply paralyze them. And they're probably not going to survive, if you want to know the truth. If they're unstable, ensure adequate sedation to a SAS of 0 to 1, proceed to cisatracurium, no role for meperidine. But meperidine is excluded, okay? You have a high frequency of seizures with the drug, and it's abused terribly by the doctors. And then the other thing it says is, look, if your machine temperature is up and you're still having trouble at 37.2, you better do a fever workup, because they're trying to make a fever here. So you have a problem separate from their cardiac arrest. They're infected now. And that's it. That's the whole protocol. I'll say again, I never hit the second page.
You see how
I'm quite certain that I've never gotten to 6.
You see how this involves us being really, really involved, because they're not gonna just do it. Like, they're just not, and they're not gonna understand it, so they're gonna fight you on it.
I have a question regarding number 3. So the patient is,
Right?
yes, if the patient's already been in the first 24 hours,
Mhm.
and we're targeting the 36 degrees, so if they're mounting of shivering, so that means I'll rewarm them during that time.
That is correct.
Okay.
That is correct.
I have
And we
a
think that
question.
that's more important than, I would rather see them target temperature management to 37 than have all this drugs dumped into them. That is true.
So that
I
means
think
it's
you do
gonna,
more harm with this than you would by bringing them up to 37.
even though if it's not
Even if you're
completed
within the
24
first 24 hours of targeted temperature management, and they should be at 36, I would rewarm them by 0.3 degrees an hour every 30, per
Yeah,
hour,
yeah.
okay? And but I haven't seen that happen there. The shivering threshold for most humans is at 35.5. So if you're above 35.5, it's actually uncommon. And Ananda keeps talking about the bear hugger, and I totally agree with that. What you're doing is you're core cooling the patient, but surface
Skin,
rewarming. And that is usually gonna be the answer.
Which is why I'm suggesting maybe bear hugger just be part of the thing that you just put on. And the reason that they fight it so much is they're like, that doesn't make any sense.
Yeah,
And even when I explain to them
counterintuitive to them.
that the Arctic sun is cooling their core, but their surface, they'll stop shivering if the surface is warm. And so for me, if you put, for most patients, honestly, you slap a bear hugger on them, that does it.
Oh, yeah. A little bit of, get their magnesium up, put the bear hugger on. If you need to, raise the temperature 0.3 degrees. Because all you're doing is you're trying to get away from their shivering threshold. Their shivering threshold is not at 35, it's at 36.2. You put them up to 36.5 and they stop shivering. I mean, that's
But the
not,
nurses
that's
are
common.
fighting this really hard. Like I've had, like literal, I know, but bear hugger's not number 1.
No, it's not number one.
Right.
Number one is their serum magnesium.
So, question, is this the same protocol that should be followed? Sometimes we have, very rarely, like, raised ICP, hypothermia,
Mhm.
TBI,
Yes.
refractory status.
Yes.
So,
Yes.
same.
Yes, same.
Okay.
And this protocol permits, so under inclusion, so it talks about ROSC, and then it says, I'm on page 2, Roman numeral 2A4. Data for other indications such as fulminant hepatic failure, traumatic brain injury, prolonged hypoxia, or other causes, or increased intracranial pressure is less robust. It may be initiated for these conditions if, in the judgment of the treating physicians, the benefit exceeds the risk. Okay? And once you initiate it, this is the protocol. You have you've used this indication, which is part of the protocol. So you're okay. Just, you're in the protocol.
And another question about the EEG. So we want it within 16 hours of initiating TTM, right?
Right.
So that's within that first day.
Yeah, I mean, worst comes to worst, the patient comes in at 4 o'clock,
Mhm.
right? And the EEG team is walking out the door,
Yeah.
okay? So they still have until, so that's
next
what,
day.
1600 until 8 o'clock in the morning to come in and do it.
And then
And
another
that's
thing.
the answer. I mean, we didn't make them come in overnight.
Yeah. Another thing, it says for at least 8 hours. Do we just want to do it for a day, or did
It's
you
8
want to
hours
keep it for
after
the
they're
whole?
rewarmed, right?
Yeah, so you keep it on
Until 8 hours after you want, and at that point,
Isn't that what it
Yeah.
says?
Yeah.
I could not find it. Where is it?
okay, that's
Where's the
page 9 at the top.
Page 9.
So at least 8 hours after rewarming.
Achieving rewarming temperature, which means there may be 3 hours to get to the rewarming temperature. The clock starts after achieving rewarming temperature. I'm saying again, there isn't another protocol in the country that has this kind of specificity. I know that.
Okay. So we don't have to keep it for the full 72 hours after rewarming, right?
If
No,
there's nothing
you
going
don't.
on,
Yeah.
no.
You
Okay.
don't, I don't. But then, let's go back to the prognosis. So I couldn't find where the prognosis is. What we typically do, it might be post.
It's on 9, 12F. Page 9, 12F.
Oh yeah.
12, right.
Yeah.
Yeah, okay, the poor prognosis protocol, this is 12E. Okay? So, the request neurocritical care to initiate poor prognosis electrophysiology protocol if the patient remains comatose or severely stuporous up to 72 hours. So in other words, you're getting on to 72 hours. You're going to be offering a prognosis soon, and the patient's not awake. Okay? I recommend, first of all, number one, make sure that all the paralytics are gone. Okay, that's with a train of 4. We do not do SSEP, that's why it says it's available. I'm still looking for a physiologist who can do that.
I can do this.
I'd be happy to implement it if we could.
Navita can
Yeah,
do
do
it.
we have?
Navita can do it, but she said we don't have a machine.
Yeah,
That's
it's-
the only
yeah.
thing.
I learned how to do it from young classes.
I
You
don't
can
know
use the
about
EMG machine
It
to
all
do it,
says.
actually. We don't have it protocolized, we could, and I will get to that eventually. Get an EEG, all right? And then initiate your family meetings. The other thing I do is if there hasn't been a CT scan, or if a CT scan was done within the first 4 hours of ROSC, right? So I would consider getting another image, usually just a CT scan. I don't find the MRI that much more helpful than the CT scan. If you can't see it on CT and you do see it on MR, I'm not sure that what you're going to do with that data. So you see a little bit T2 hyperintensity, some cortical ribbon, and the CT scan is normal, let's see.
I think you can sometimes see shearing injuries and brainstem injuries that you might not be able to see on CT that would be helpful.
You might, but I don't think it gets you. Of course, the brainstem is less sensitive. So now, if you had reason to think that there's a brainstem injury, then you're working up a brainstem injury. That's a different matter. I would also say that we had a patient that was isoelectric on their EEG. So we did the EEG, and then following the protocol, before we took it off, at 8 hours after rewarming, it was isoelectric, it was flat. So we left the EEG on, we didn't take it off, okay? And we continued it, okay? The patient regained brainstem reflexes. We looked at the patient and continued to have a flat EEG. We said, this does not look right. So we sent them down, in this case for an MRI, and we saw total edema and hyperintensity of the cortical mantle. It completely wiped out the cortical mantle, okay? And was, we could say, well, this patient's going to end up vegetative.
Yeah, the brainstem's intact, but.
Yeah, the brainstem's intact, but nothing else is. And he's a flat EEG. So we're not going to be declared brain dead, but we're telling the family, not a chance in the world this patient's waking up. That's our prognosis, not a chance in the world.
We need to discuss the poor prognosis electrophysiology protocol and the brain death protocol on some other day.
Okay.
Because I don't know, if there's no EEG in the brain death protocol, right? Or
There
is
is
there?
no,
It's
No.
definitely not.
Yeah,
You don't want an EEG in the brain death
Right.
protocol.
It's a secondary test.
okay.
It's not even
supportive.
secondary. No, it's
It's
not.
supportive.
Nothing.
I think it's supportive. I
Nothing.
think it's supportive.
Let me tell you
Should
something.
we
I
arrange
have the
another day?
article, okay?
Yeah.
There was an article
Mhm.
that was done, because when you do 2 microvolt with double the electrode distance, okay? There's an EEG that was brought out and published, okay? And then afterwards, after the publication, the people who published the article, okay, wrote a letter and said, that article, that EEG that we showed you, was obtained on a bowl of Jell-O. That's the truth. And that was the end of the EEG. in brain death.
Again, we're gonna hang on.
So we're gonna
Anyway,
arrange
I think
another
it's,
day.
I think,
Yeah.
I'm not saying secondary, I will retract my secondary statement. I think supportive, it's.
I always
helpful
think the
for-
EEG is useful, okay? I like EEG, as you all know, in the ICU, I use EEG a tremendous amount, but I don't use it for brain death.
No, but it isn't part of brain death, I agree with that,
Yeah.
but that's not part of the actual brain death.
Yep, what else, Emma?
So just we
We
need
can do
another
that.
date, that's
All
all.
right,
We'll
that's
do
fine.
something in
Happy to
December.
do it.
or-
We can take a morning report, we can do whatever you want.
Why don't we do a general talk before that, and we can talk
Yeah.
about, each one of
General
you
talk.
can take like a little segment, but